taken out because you want to avoid proximity to the breaths or airways. And then you go about your chest compressions in the same manner that you will do. So you no longer listen or feel for breath sound to diagnose the arrest. You just feel a pulse on the carotid for 10 seconds and then commence CPR if you have confirmed arrest in a normal protocolized way. So this is a hospital simulation of a CPR. You can see there are minimal number of participants in the room. Everyone has full PPE kits with the visors, the mask, the hats, the long gowns and the gloves. Anesthetist at the head, someone documenting and making sure that the right medications and protocols are formed. And you only do chest compressions when everyone in the room has a level 3 PPE. So you do not start chest compression until everyone is gowned, because you put everyone at risk. So in the hospital, we use the same. So you go through your normal sequence of 30 compressions to 2 breaths. And again, you use a bag mask valve, which has a fitted filter attached to it, and you create a tight seal. And then when you get your intubation, you can do your continuous chest compressions. And then as usual, you go through your 4 H's and your 4 T's as part of your algorithm, and then check if you've got an ITU bed available very early on, because this will have to be the end point in terms of getting your patient to. As a cardiologist, in terms of the cath lab, we treat everyone as if they've got COVID-19. And so what that means is everyone has a full PPE kit. And again, as we've been through before, the visors, the masks, and we consider the full PPE kit for everyone who comes in with an ST elevation, myocardial infarction, or those who have a high-risk NSTEMI case. This is our gown we wear. So again, repeating what I've said, the visors, the masks, the respirators, and the gloves. And this is very important. So it's very important that you don your gown, clean your hands, don your gown, and particularly when you're taking it off, the doffing is the important bit, because that's when you can contaminate yourself. So it's very good to do that in pairs and to practice, practice, practice. So in the cath lab, we make sure our patient has a mask to prevent the spread of any aerosolization. We also wear a mask. And it is very important that we practice this, because the first time you do it, you're not used to having to wear PPE. So it's very important you do regular simulation type practice, because practice will be key to success for you to get quick. Also update your local protocols with regards to how CPR is done and the need to wearing your PPE kit, and education through videos, webinars such as this, and podcasts are very important. So that's just a quick summary of resuscitation. Happy to take any questions, and hope I've got you some time back.
Thank you very much, Dr. Akul. Thank you for going through all of those points about resuscitation in COVID. I had one question about in the cath lab. So does everybody in the cath lab wear full PPE in terms of the full FFP3?
Yes.
Yes, okay.
Yes, so everyone in the cath lab, so all patients are treated as COVID positive. And the reason for that is really we are trying to minimize healthcare workers from getting infected. We've had situations where we've done a rapid COVID swab, which has come back negative, and then subsequently the PCR is positive. We've had also vice versa, where the rapid one is positive and the lab is negative. So there is some reduced sensitivities of the test. So we have to protect healthcare workers and prevent the spread between patients. So we all wear full PPE kits.
Okay. Yes, in our center, we have the first operator, the second operator, and one scrub nurse who wears full PPE, full FFP3, but everyone else wears the standard PPE. Okay. So Dr. Saeed, I think you had a question.
Yeah, assalamu alaikum everyone. Dr. Emmanuel is doing what you do in the cath lab, a diagnostic or interventional PCI, an AGP?
Yes, so we're not doing any diagnostic procedures in the cath lab. They're all graded as being emergency or urgent outpatient work, except for patients who've got significant valve disease and need to have an angiogram procedure before it. but these are all patients who are deemed to be emergency or high risk, and so by definition are at high risk of going off in terms of having a cardiac arrest.
Right, so is it in anticipation of a cardiac arrest you
It is, absolutely, yes.
Procedure is not AGP, but the subsequent procedure is. That's
so
what I want to clarify.
It's in anticipation of a cardiac arrest, that's correct.
Okay, fair enough.
So there is guidance from the BCS and the British Cardiovascular Intervention Society and the British Heart Rhythm Society regarding what's an aerosol generating procedure in cardiology. And if you have a primary PCI, would classify as a aerosol generating procedure, whereas PCI for stable ACS is not. So there is a distinction.
Yes, that's true. That's true. I think it's the risk of someone having an arrest, and so by definition, a STEMI and a high risk ACS. Yes, correct.
Okay.
Can I just ask a quick question, if that's okay? Thank you much for the presentation, Emmanuel. So when you talk about the PPE for cardiac arrest situation for COVID patient, I guess you're talking about people who are confirmed to be COVID and people who are suspected to be COVID as well. The precautions are the same. Is that right?
Yes, that's correct. So if you have a high suspicion or someone is confirmed, it's a full PPE kit for the resuscitation team because it's aerosol generating.
May I ask, I mean, do you think that would put a significant delay on patients' resuscitation in case if there's no sufficient staffing in PPE at that time? It might be applicable to certain places that you might not have enough staff in PPE ready to go for the CPR, but a significant delay, because my understanding that PPE take a while to put it on and have the gown and everything. So what's your take on that?
And that's my exact point, why I said there's the absolute need to practice. And so this can be, so for example, in my institution, we had a kit for practicing. And so you don't have to waste PPE kit for the simulation runs. And so all the team had to practice this over and over to get quicker. Now, putting on the FFP3 mask and the visor is quite important, but the more you practice, the quicker you are at doing it. And I think the risk is really balancing between the risk of getting infected as a healthcare professional and not being able to provide that care for the rest of your patients versus running in without any protective gear. And I think even our resuscitation council advised that if you don't have the full PPE kit, you shouldn't start CPR. And I think bodies around the world should almost put similar type of guidelines for their healthcare professionals. So it takes it out of the hands of the healthcare professional, but it's a body that's recommended that because it's a highly contagious virus.
Thank you very much.
Just to add to that, so in our center, the primary operator and the second operator and one scrub nurse are wearing full PPE. So if there was a cardiac arrest, everybody who's not wearing full PPE would leave the cath lab, and we use a separate cath lab, a dirty cath lab, and the CPR can be commenced. So yes, there is a delay, but you're minimizing that delay because when the other team who are donning their PPE, that can be done outside the cath lab.
Very good.
Yeah, I think that the difficulties are the ward-based patients where not everyone always has the full PPE ready to go, but the arrest team coming in should make sure that there is they're completely protected.
Okay.
Right. So,
thank you very much, Dr. Emmanuel. And now I would like to introduce our next speaker, Dr. Lina Sulaiman. She is going to talk about emergency assessment and management of COVID-19. I think she had two interesting case presentation. Over to you, Dr. Lina.
So I'm going to touch fairly briefly on the emergency assessment and management of COVID from the front door into the ward, and then I'll speak about two interesting cases. So moving on to the second slide, please. And this is the agenda for the session. So triage and initial assessment, venous thromboprophylaxis, entry.
Dr. Sulaiman,
case presentations. And
sorry to interrupt you, Dr. Sulaiman. We can't quite hear you. Would it be possible to perhaps position it a bit closer so we can hear? We can't actually hear it very clearly.
Okay.
Yes, that's better. Yeah.
Can you hear me better now?
Yes, that's better.
Okay. Okay, perfect. Right, so again, the agenda is triage and initial assessment, venous thromboembolism, antimicrobial treatment and protocol for our hospital, 2 case presentations and a conclusion. I'll speak fairly quickly because I know that we're limited with time. So our case definitions for coming into hospital is basically a patient who needs to come into hospital, having either clinical or radiological evidence of pneumonia, acute respiratory distress, or they've got influenza-like symptoms with fever, cough, and breathlessness. Mild COVID is mild symptoms, basically fever, fatigue, cough, with or without sputum production, anorexia, malaise, muscle pain, myalgia, sore throat, dyspnea. In mild cases, we don't usually give them any treatment. We don't usually admit them to hospital, and we send them home. Severe COVID, these are our criteria. They're not fairly specific, so we had to do a lot of clinical decision-making patient by patient. So if the patient is above 55 but fairly stable, you would still send them home. If they're immunocompromised but fairly stable, we'll still send them home. So these criteria, although they are our criteria for hospital, they allowed us to make individual decisions for each patient rather than follow a specific guidance. Even patients with biochemical changes with high D-dimers and elevated troponins or ferritin levels who were clinically stable, you would have still discharged into the community with a bit of outpatient follow-up. Obviously, if the patient is septic, they would need to be admitted, and the protocol is different. And people with septic shock, who are basically people who come in with COVID symptoms and are persistently hypotensive despite fluid resuscitation. And we've got patients who develop ARDS or acute respiratory distress syndrome, and these patients eventually do end up in the intensive care unit if they're well enough or fit enough to go there, if not too frail, and we made a decision early on that they wouldn't be for intensive care. Moving on to this slide. Thank you. So our antimicrobial treatment for Chelsea and Westminster Hospital. So if they had mild COVID, we wouldn't give them anything and discharge them home. If they had severe COVID, you would give them 1 gram of amoxicillin orally or 2 grams intravenously 3 times a day, plus an atypical antibacterial, which is usually doxycycline, azithromycin, or a macrolide. If they had severe COVID with sepsis, you would escalate our antibiotics to ceftriaxone once a day with an atypical antibacterial cover as well, and a shot of amikase and a shot of aminoglycoside. If they had ARDS, we would just give them ceftriaxone, atypical antibacterial, but we would refer them on to intensive care at that point in time if they were deemed fit enough to go to intensive care. In terms of our VTE prophylaxis, that changed about 3 weeks into the COVID crisis at Chelsea and Westminster, because we noticed that patients had high D-dimers and had increasing D-dimers. So our usual patients who do come into hospital, whether they're COVID or not, we started them on VTE prophylaxis, which is venous thromboembolic prophylaxis, which is usually about 40 milligrams of enoxaparin or low molecular weight heparin once a day. But in COVID patients, our guidance has changed to BD dosing. And when patients were discharged home, we discharged them home on a DOAC, especially if they were in hospital for at least 7 days, or if at any point during their admission, they needed HDU or intensive care admission. For acute thrombosis, DOACs were not usually recommended in the acute phase. We used low molecular weight heparin or unfractionated heparin, depending on the renal function. And we monitored fairly closely for DIC and coagulopathy as well. So moving on, I'm going to speak about a couple of interesting cases. So I have a 40-year-old chap who initially had 2-week history of myalgia, sore throat, fairly specific for COVID as such. He attended a different hospital, and during his hospital attendance, which was less than a day, he was swabbed, and the swab came back positive for COVID, but a new murmur was heard, and he was discharged with an outpatient echo. He then developed fever, cough, and breathlessness since he was discharged from the other hospital, and he stayed at home, but when the breathlessness became too bad, he came into hospital. He came to our hospital. His white cell count was not raised. His lymphocyte count was normal. His CRP count was raised though. He had a normal hemoglobin with a low MCV, which was new to him. He wasn't aware that he had any hemoglobinopathies. He had a high D-dimer and high ferritin level and high LDH and a normal troponin. His chest X-ray showed basically bilateral aerospace opacification, worse on the left-hand side. He had another COVID swab with us, which was again positive. And this man was very anxious. So although he didn't require very much oxygen, he only needed 5 liters per minute of oxygen by nasal specs. His respiratory rate was extremely high. It was 40 at one point in time. And he was complaining of a bit of pleuritic chest pain after coming into hospital, which developed in hospital. So he went on to have a CTPA, despite his D-dimer not being that raised. It was high, but not that raised. And this CTPA did show a subsegmental PE, and he was started on treatment dose enoxaparin. He received regular antibiotics. He would have fulfilled the severe COVID criteria. So he was given IV amoxicillin and doxycycline through 3 days. He had persistent fever. And then with the new murmur, it was thought maybe it would be best to cover him for infective endocarditis. He required CPAP for only 1 day, or actually it was just about 5 or 6 hours. And it was mainly because of his tachypnea rather than his poor oxygenation. This was stopped fairly quickly. We're moving on to the next. Thank you very much. So he was suspected to have endocarditis, not on a TTE. The TTE didn't show any vegetation. It just showed severe aortic regurgitation. Despite that, he was started on flucloxacillin, amoxicillin, and gentamicin to cover for endocarditis after discussion with both cardiologists and microbiologists. He was then transferred to tertiary center to have a TOE. But he never had a TOE. They reviewed his TTE and they felt confident enough that he didn't have a vegetation. So he was discharged home without any antibiotics. He had another CTPA in that tertiary center, which didn't show any clot. So he was discharged home without any medication. He presented the day after again to our hospital with worsening breathlessness and new right-sided pleuritic chest. And this is his chest X-ray. It basically shows, again, aerospace opacification, mainly in his upper zones, but it shows which is quite rightfully reported as an encysted hydropneumothorax. But because of his degree of breathlessness, he went again to have another CTPA. Next slide, please. Thank you. And his CTPA did not show any clot, but it did confirm the presence of the encysted hydropneumothorax, which you can see with the blue arrow. He was treated initially with just analgesia, a bit of chest physiotherapy, and we restarted his anticoagulation again at a prophylactic dose, and we discharged him 3 days later once his pain settled. He went home, got worse, started developing a fever, and he was readmitted again. This time, the diagnosis was an infected encysted hydropneumothorax. He had a raised CRP during this admission. He was started on intravenous antibiotics, and he also had some oral metronidazole, and he improved on that. So he had a hospital stay of about 5 days, and he was discharged on oral ciprofloxacin and metronidazole. If we can move on to the next slide, please. Okay. This is another view for the encysted hydropneumothorax. He continued on the ciprofloxacin and metronidazole for about a total of 3 weeks post-discharge, and he was reviewed on a weekly basis in our ambulatory care unit. His D-dimer started rising, and his breathlessness never went away. And despite having 3 CTPAs, the initial one showed a very tiny segmental PE, but 3 CTPAs after that with no obvious PEs, it was felt that he may still have some small PEs that we couldn't pick up on our CTPAs. And his D-dimer peaked to a peak of 2,500. So we discussed his case with hematology, and it was felt on balance or probability that he might have an underlying PE, so he was started on treatment dose DOAC. On both the antibiotics and the DOAC, he improved massively, and the last time he was seen was a few days ago, and he's like a different man. His X-ray changes and CT scan changes have improved as well, but not as much as he has clinically improved. If we can move on to the next slide. So the pre-treatment one is on the right, and his post-treatment one is on the left. And we can see the measurements of the pre-treatment one. And also we can see a lot of consolidation, both superiorly and inferiorly on the right side, and a little bit on the left, which have improved massively on his post-treatment one. This man had a prolonged treatment for his encysted hydropneumothorax, and it's taken him quite a number of weeks to get over his COVID pneumonia. So if you move on to the other cross-section, and we can see here, it's a little bit clearer that the encysted hydropneumothorax is much smaller. It doesn't look like a hydropneumothorax anymore. There seems to be a bit of echogenic material there. So whether he's got encysted consolidation or of this fluid, it's difficult to say, but clinically he's much improved. If we can move on further. So like Marcella said, who's my ITU colleague, we usually do reviews for each of our patients, and patients who have stayed in hospital or have had recurrent hospital admissions or high morbidity, we reflect on what we did well and what we could have improved. For him, I think the initial treatment was totally appropriate. He had good follow-up plans made. He had a multidisciplinary team approach for his case, where we included both acute physicians, respiratory physicians, microbiologists, and cardiologists. We had the benefit of using our ambulatory care to give very good continuing care, and we had excellent communication between the teams. For him, what we could have done better, and it's easy for me to say in hindsight, maybe he shouldn't have been started on the CPAP because he only needed it for 5 hours. And I think there was a high element of anxiety there rather than actual indication for CPAP. But in the middle of the night, when you're the registrar on a busy take, you need to make a judgment call. And the judgment call was to put him on CPAP, and I support my registrar fully, but I don't think he needed it at all. His transfer documentation to the other hospital, his tertiary hospital, we should have suggested that he should have gone on an outpatient BTE prophylaxis on discharge, which he didn't have as per our guidance. But I think that was missed because he was transferred on treatment dose to treat VTE, which was stopped on discharge from the tertiary hospital. I don't think he should have gone to the tertiary hospital at all, because what they did is basically just keep an eye on him and review his images. I think we could have done that remotely from where he was in our hospital, rather than transfer him to a different hospital for him to be discharged from there. So I think this is what we could have improved it on this case. I'm going to move on to the second case, as I know that we're running out of time. This is a 48-year-old gentleman who's a colleague who had SARS-CoV symptoms of fever, loss of smell and taste, and cough for about 12 days. And then he had 3 days worth of azithromycin. His symptoms then resolved. And because he was a colleague, he had to return back to work. And he was on call the first day back, and he then developed a headache and high fevers with temperatures of about 39 and some neck stiffness as well. And he felt that he wasn't functioning 100%. He couldn't think straight. He had some bradyphrenia. He didn't have any rashes or herpetic eruptions or anything. Examination, he looked quite unwell. He was photophobic. He had a normal neurological examination. His chest was clear, despite the fact that he had COVID symptoms a few days before. If you move on to the second slide. So in his case, his investigations initially, apart from an eGFR of 66, they were fairly unremarkable. He had a CT head and a CT venogram, which were normal, and he went on to have an MRI head, which was also normal. He had an LP because of the headache and the ongoing fevers, and his opening pressure was fairly fine. His CSF white cell count, however, was 125, with mononuclear cells, 98%, and a high protein of 1.57 grams per liter, the upper limit being 0.45. He had a normal lactate and a normal glucose, so it was suggestive of a viral meningitis picture. So he was initially started on ceftriaxone, but that was stopped after the CSF results, and we started him on acyclovir then. And then we got our CSF result back. If we move on to the next slide, please. And his CSF PCR basically didn't show anything apart from EBV, but he had low copy number. His SARS-CoV was also tested on the CSF. It was negative. Given the low number of EBV, our neurologist felt that on balance of probability that this was still COVID-related aseptic meningitis. And he tested positive on his nasopharyngeal swab again, but he didn't have any ongoing respiratory symptoms. So we stopped his acyclovir and he was discharged. For this case, what we did well is that we promptly rearranged ourselves to take over his service. So one of us fairly quickly came to do the on-take and post-take. We referred him to an external specialist. So one of our neurology colleagues took over his care, so that we didn't have to make difficult decisions for a colleague. We could have done better. Analgesia, I think he was in a lot of pain from the first night. If we maybe gave him something stronger, it might have helped with his overall recovery. But also in our colleagues, we tend to not look after ourselves as medical care professionals. He had a prolonged course of respiratory symptoms. He also needed to have some azithromycin to improve his respiratory recent symptoms. And the
Sorry, Dr. Lena, I think we lost you. We lost your voice completely. We can't hear
who's on
you.
call. I think for him and for all our colleagues, post-COVID return to work chat or interview to see if they would be a better option for all of us. I think the best thing is to disconnect and come in now.
Yes, we can hear you now, yeah.
Okay, perfect. So take-home messages. We need to approach these patients in a multidisciplinary team. So physicians, intensivists, respiratory physicians, we need to be able to communicate well within our teams, so good teamwork. Our vague case severity definitions to begin with in our hospital gave us our own room to clinically evaluate each patient and tailored treatment to each patient individually. Clinical judgment was the mainstay for both the diagnosis and management. And I think reflection is very important for all cases that we manage, whether they are admitted for a fairly short period or if they've had quite a complicated course of treatment. And thank you very much.
Okay.
Thank you.
Thank you. Thank you very much, Dr. Lena Suleiman. That is a fantastic talk. And I think we would like to ask if there's any comment or question from the panel.
Dr. Saeed?
Yeah, assalamu alaikum. Interestingly, do you have available PCT in your hospital, procalcitonin, as a biomarker? Yeah.
We
do you have that available to you?
Calcitonin, but we only introduced that in April. So for the first case, the chap who came in with the insisted hydropneumothorax, when he initially was in hospital, he didn't have any procalcitonin, but subsequently he had procalcitonin levels which were quite normal.
Yeah, so in one of your protocols, in the mild you were giving antibiotics upline, right at the front, even mild cases. What was
for our mild cases, we weren't giving any antibiotics at all. We were basically...
I must have not seen that slide. Yeah, it was mild to moderate. You had amoxicillin as a protocol for all patients, which I found interesting because it's a viral condition. It's only those.
So no, our antibiotics are only for severe COVID. So we didn't have mild. We basically had either mild COVID or severe COVID. We didn't have any moderate COVID. So for our severe COVID, we started with amoxicillin and an atypical, and severe COVID with sepsis, we gave a ceftriaxone and an atypical with a shot of amikacin. But we don't have moderates, and we do not advise or advocate antibiotics for patients with mild symptoms. Okay,
fine. That makes sense.
Thank you. I think we have a question from the audience here. I think the question direct to Dr. Emmanuel. Is there any difference in resuscitation COVID from non-COVID patient?
So I think that's a very good question. I think a lot of the difference is around donning of the PPE before you start, and then the way that cardiac arrest is confirmed. So before, with the listening and the feeling of breath sound, so that's been removed from the algorithm. So you just feel for the pulse for 10 seconds to confirm cardiac arrest. So I think that's a significant difference between the COVID versus the non-COVID patient.
Thank you. And I think the second question also regarding the same topic, I think, but regarding the first responder in CPR patient in cardiac arrest. And they asking, can the first responder start CPR with surgical mask only?
I think it's a really difficult, it's a difficult personal question. It's a difficult ethical question. What we know is that CPR is an aerosol generating procedure. And with aerosol generating procedures, you need the maximum protection that you can get. And that would be with an FFP2 or an FFP3 mask. So personally, I think if you had that available, I would recommend that you use that. It's also worth discussing it as a group before you have to encounter one of these scenarios and come to a consensus. With regards to CPR in the community, the advice is that you cover the victim or the patient's mouth and nose, and you wear a mask before you do CPR. But that's because that's anticipated that that's in the public, in the air, in the open, and we know the transmission is lower in the air or in open spaces, whereas confined spaces, CPR is aerosolized generating. But any comments from my further colleagues on the panel would be useful.
Okay, thank you. Over to you, Dr. Ahmed.
Yeah, I just wanted to ask Dr. Suleiman about the first case that you presented. It was a very interesting case with that patient who had a new murmur of, and was subsequently found to have aortic regurgitation. Were there any blood cultures done in that patient?
Yes,
because obviously that can sometimes guide your management.
So he had 3 sets of blood cultures, and all of them were negative. He had sputum cultures, urine cultures, everything was negative. So we never grew anything from him apart from the COVID PCR.
Okay, great. Thanks very much.
Thank you. And I think during Dr. Abi talk, I think we got a question from Dr. Saeed Ahmed. I think that question direct to Dr. Abi with regard the study endpoint was changed halfway through the study. Dr. Ahmed, would you like to?
Yeah, thank you very much, Dr. Abi. A great overview. So the studies for remdesivir, as Dr. Fauci from the States, who has been pushing them quite a bit, and he said a very interesting statement. He said this was the new standard of treatment. Well, it's nowhere near standard in this country to use remdesivir at this stage. And from my understanding, the study endpoint in the study that you pointed out maybe was changed halfway through the study. Study endpoint should have been a hard endpoint of mortality, but when the investigators were doing interim analysis, did not find that the hard endpoint would be reached. They went fishing for some positive endpoint, and the most positive they can point out is what you pointed out, was the recovery time being slightly quicker by 4 days. Now, I don't know if that is the case, but did you find that in your reading?
So thank you. That was a very good question. So when I looked at the papers that actually published and looking at the small points that was drawn up, that actually this study didn't reach total conclusion. As you know, there are other studies that currently are looking at remdesivir. So the recovery trial is looking at the use of remdesivir with other combination drugs as well. Yes, it didn't reach a statistical analysis kind of significance. It didn't reach a hard point. And I think it was cut shortly or abruptly because they knew that, you know, even if they ran this for another 2 years, they wouldn't achieve that data. And it was just, you know, I think what we need to do with all of these trials, take it with a bit of a pinch of salt. It did show some difference in the duration of the illness the patient had. I don't know if Marcela is still on board, whether she's had any experience with using remdesivir, because essentially, what, you know, they used it in kind of moderate to severe patients. Not a lot of these patients were on ECMO mechanical ventilation. It may have a role, but I don't think the role is exactly known. You know, maybe it's to be used in a milder condition rather than severe condition. I don't think we're there yet, but yeah, there was a change in plan of that study, and I don't think it's currently protocol drug to use. It's on compassionate use in many places. Marcela, I don't know whether you've used it in ITU with any of your patients.
So basically, we haven't used. So basically, one of my problems, or our problem in intensive care, the disease progression will differ from one patient to another. So randomizing patients, into clinical studies when we didn't know the course of disease, we didn't feel it was right, because if the patient didn't have a cytokine pattern or thromboembolic pattern, or was a mix of things, the drugs that we were introducing, the side effects were more, the patient were at high risk of dying because of side effects or complications of the drugs, and not because of the disease. So as I said before, we moved to basics, understand the process of disease, understand the different times of the disease, so then we can introduce drugs accordingly. At the beginning, was very, very difficult to accept any clinical trial or randomize the patient into clinical trials, because we didn't feel it was right for them. We were taking their chances away. And that happened actually in a lot of centers. And we proved to be right, because a lot of studies actually show that were no benefits. We need to start looking into more details of the patient who died in those clinical studies as well. So I think there is a lot to say. I think that we all learned from the research as well. So now probably the inclusion criteria for clinical studies will be modified, and that will help us to globally, not only in intensive care, but in hospitals and the community, to randomize the right patients into the studies. But that was our view at the beginning. So sorry, yeah.
Thank you for that.
Okay, thank you. Had anyone had any comment or any question? Dr. Hatim, Dr. Ahmed Adlan?
No, I didn't have any other questions actually. I think it was all quite very thorough. Thank you.
Maybe just one last question to Abby, if you don't mind. Abby, are you aware of any data in HIV patients who have been on antiretroviral therapy, whether that has any preventive role or made them less likely to contract the infection or made it less severe? I'm not aware myself of any data.
So there was, when I was looking at this, there was a couple of small studies that looked at small case cohorts of patients who were HIV, who had COVID-19. But again, these weren't any randomized control trials or big studies that could be quoted in numbers. What I can tell you from the HIV team, because I work quite closely with some of them, is that they are not seeing huge number of patients with HIV that would come in with COVID-19. And I think one of the reasons they say it's not just because of the drugs, is that these patients are probably very good at self-isolation. They've learned, through life and experiences, how to prevent themselves from getting the flu virus and other infections. So there may be some behavioral learned kind of action that they are able to take better than the rest of the population. But in terms of, yes, maybe retroviral therapy is protective to some cases. I don't think we saw an influx of HIV patients with coronavirus during, the times that we thought that we would see an influx of them. So there may be some protective benefit from some of these drugs, but I think some of it is also environmental, as well as they're pretty good at kind of keeping themselves isolated and kind of shielding for long periods of time. And I think they've done, that's probably one of the success reasons we've seen little of these population present to hospital.
Thank you.
Okay, thank you very much, Dr. Abby, and thank you very much to everyone. I think we're going to bring this session to a close. It's been fantastic having you, and we're really pleased that you've made the time to join us from Chelsea and Westminster. So we would just like to remind everybody that we have another up and coming webinar for part 2 of webinar 4 on Saturday, and we would very look forward to for you to join us. So thank you very much, and I'd like to pass it on to Dr. Abdulazim.
Thank you very much, Ahmed, and I would like to give a big thanks to Dr. Abi and to Dr. Hatim and to Chelsea and Westminster Hospital team for this great initiative, and it was a fantastic talk. This talk is going to be ready in next few hours on the YouTube channel, and will be also published on Facebook, and we will pass it to you. And we will also be sending the question out to the audience for the assessment. I would be very grateful if all the speakers just can give us at least one question for each session, just to put it on the assessment form. And I would like to ask Dr. Hatim just to close the session. Dr. Hatim Ali.
Thank you, Abdulazim. And I think it was a fantastic discussion, very practical points that was raised by all the speakers. Probably we meet on a daily basis in our practice. So I think it was very fruitful. Thank you very much to all of them. And many thanks to Abby herself for organizing all of this. And hope to see you in more collaboration in the future.
Thank you very much for the invite.
Thank you very much. Thank you.
Thank you. Thank you very much for the invite.
Thank you.
Stay safe.
Take care. Bye-bye, guys.
Thank you.
Bye-bye.
Bye now.
Bye.
Thank you. Bye.